Presented with chief complaints of abnormal movement of all four limbs since last 9 months, difficulty in writing since 9 months, difficulty in walking since 5 months, difficulty in speaking since 3 months, and behavioral changes since past 3 months.
Please go ahead.
Yes. History of presenting illness. As per informant, patient was apparently all right 9 months back. Her teacher noticed abnormal movement of right upper limb, which was insidious in onset and progressively involving all four limbs within a duration of 1 month. The movement were involuntary, jerky, rapid, rhythmic, purposeless, repetitive, with both proximal and distal involvement, and symmetrically involving all four limbs and were painful. These movements were aggravated on walking or any type of stimulus and relieved during sleep. Frequency and duration of movements increased over a period of 4 months. Initially, movements occurred 5 to 6 times a day, lasting for 1 to 2 minutes, and now movements occur 10 to 12 times a day, lasting for 5 to 6 minutes.
Go ahead.
Child has difficulty in writing since 9 months, was unable to hold pencil of her own, and eventually stopped going to school. Difficulty in walking started 5 months back. Child became clumsy and started having frequent falls due to exaggerated movements and stiffness of the limbs. She was able to walk with support for past 1.5 months, but for past 20 days she stopped walking even with support and just able to stand with support. She was unable to perform daily activities since 4 months. She could not eat by herself, comb her hair, and wear clothes. Patient also had difficulty in speaking since last 3 months. Initially, she had slurring of speech and managed to speak few sentences. She was unable to understand commands. Her speech was slow and indistinct. It deteriorated gradually. Fluency, repetition, and naming is also affected. She tried to speak a word but could not complete it. She was emotionally labile since 3 months. She kept smiling and suddenly started crying. She was irritable and not playful as in the past. And there is no history of seizure, abnormal posturing, altered sensorium, abnormal eye movement, vertigo, headache, vomiting, blurring of vision, or skin rash, oral ulcers, excessive sweating, fever, cold or cough, chest pain, breathlessness, icterus, abdominal pain, or drug intake. And no history of bladder and bowel disturbance. Past history, no history of similar episode in the past, and no history of previous hospitalization or blood transfusion, and no history of infectious disease like in the past, like measles. Antenatal history, all 3 trimesters were uneventful. It's a book case. Iron folic acid were taken. Two doses of TT were also given. No history of diabetes, hypertension, fever, skin rash, or smoking or tuberculosis. And in natal history, child was full term, normal vaginal delivery at hospital, and birth weight was 2.5 kg, tried immediately after birth. Postnatal history, no history of an ICU admission, breastfeed started within 1 hour of life, no history of neonatal jaundice or neonatal seizures. All milestones were achieved as per age and immunized as per national immunization schedule. In dietary history, patient was exclusively breastfed for 7 months, and complementary feeding started at 7 months with the dal khichdi. Child was taking mixed diet, and calorie there is a deficit of a calorie of 400 and deficit of 20 gram protein. Personal history, diet was mixed, sleep pattern normal, and bowel bladder regular. Menstrual history, menarche started at the age of 13 years, 2 months before admission, and SMR staging were 5. Family history, father 40 years old, mother 35 years old. Patient is 4th in birth order, born to non-consanguineous marriage, and no history of similar complaints in the family. Socio-economic history, on a kacha house, 8 members, 4 rooms. Father and mother both were illiterate, and sanitation was poor, and drinking water by hand pump. and occupation by farmer. Per capita income was 1250 as per BG Prasad scale.
Okay.
Summary.
No, don't worry about summary. You go back to the first slide. Go back, very nice history. You've taken almost all the points which are required. Now, my first question to you, there are 5 complaints you have mentioned.
Yes,
Okay. With these 5 complaints, see abnormal movement of all 4 limbs since last 9 months, then difficulty in walking, difficulty in writing, then difficulty in walking, difficulty in speaking, then behavior change. Then, please go to the next slide. Go to the next slide.
Yes.
Go to the next slide. I appreciate your first sentence because, go back to the previous slide. I appreciate your first sentence. You have very clearly informed us that this child was normal, school going, and developmentally she was normal. So everything started only in the last 9 months. I appreciate you once more. Go to the next slide. It was first the teacher who noticed the movement. Now I'm going to ask you a peculiar question. School teacher observing abnormalities is a very, very important clue to 3 diseases in pediatrics, neurological illnesses in pediatrics. Or maybe I would even say 4. What are those 4? Neurological problems. School teacher observing very sharply. I would say 5 conditions she will observe. She is the first one who would bring to the notice of the parents. Can you tell me which are the ones? Anybody can put in the chat box. Absent seizure, excellent. Somebody has put in the chat box, absent seizure. I mean, it may not get noticed even by the parents. In the school, the teacher would notice. Very nice, very petit mal absences. Okay, very nice. That's 1. 2. Wilson's disease, excellent, excellent. Atindra Jain, somebody has put it correctly. What does it manifest as? Wilson's disease. Intellectual deterioration. Child previously doing very well in school will start deteriorating. Not only Wilson. Somebody has put autism spectrum disorder. Excellent. The school teacher may be the first one to say the child is hyperactive. Next, anybody? Yes, Dr. Atul.
Yes, sir.
Anything else? Close to Wilson's disease, rheumatic chorea. Rheumatic chorea. Mother might not notice. The school teacher will notice that the child who is performing so well has suddenly started deteriorating and handwriting is becoming bad and the child is becoming fidgety. Last is subacute sclerosing panencephalitis. Intellectual deterioration may be first noticed by the teacher. Okay. In fact, my professor used to say school teachers noting abnormalities are frequently seen in Wilson's, SSPE, and rheumatic chorea. 3 important conditions other than what we mentioned. Okay. Right.
Yes.
You had described the movements. What movements do you think these are? What movements are they?
Sir, these are likely to be coriform movements.
Coriform movements. Why do you say coriform? I am saying this is a seizure.
Sir, but patient when presented, she had intact consciousness, and there are no.
But consciousness need not be there in every seizure.
Yes, sir.
Need not be there. Impaired consciousness need not be there in every seizure.
And sir, our patient was also responding to commands.
No. See, you should have asked whether the movements persist during sleep or not. If they are persisting during sleep, that tells you it is seizure, because all basal ganglia involuntary movements will completely disappear during sleep. I think that's what you should have absent. That's what you should have asked. So in addition to loss of consciousness during episodes when there are generalized movements, you cannot have a child who's throwing jerky movements of all four limbs without loss of consciousness unless it's a pseudo seizure. Okay.
Yes, sir.
Right. Choreo, is it what is it? Chorea or choreathetosis? Because you have mentioned both proximal and distal. Chorea is proximal or distal?
Sir, chorea involves both proximal and distal.
No, chorea is usually proximal. Athetosis is usually distal.
Distal.
Here you have put both proximal and distal. You can only say it could be choreathetoid movements, extrapyramidal involuntary movements. Okay.
Yes.
Now, and hello?
Hello?
Hello. Okay. Okay. Next slide. Next slide. Next slide, please. Go to the next slide. Yeah. Writing. Writing. What was the difficulty in writing? He dropped the pencil, or handwriting became bad, or he had microgyria or macrogyria. There are two types of handwriting disorder. One is child may previously used to put big letters, now will put small letters, and the other way.
Sir, yes, sir. Sir, when she start to hold the pen or pencil, then she start the shaky movement, and
in extrapyramidal disorders, will there be microgyria or macrogyria? In cerebellar disorder, will there be microgyria or macrogyria?
Sir, in extrapyramidal there will be macrographia. Macro.
Okay. Okay. That also you could have found out. Okay. Right. Difficulty in walking, fall due to exaggerated movement, stiffness of the limbs. Stiffness of which limbs?
Sir, stiffness is
All
present
four
in
limbs
all
or
four limbs.
upper limbs or lower limbs?
Sir, stiffness is present in all four limbs.
All four limbs. Okay.
Yes.
What do you mean by she was unable to perform daily activities? Which daily activities she could not perform?
Sir, she was unable to eat by herself or and not able to do her daily chores like brushing her teeth or dressing herself.
What about toilet needs?
No, sir.
That's very important.
Yes, sir. Sir, sir, she was not able to go alone with the toilet since she was having a abnormal this movement, involuntary movement. But she can tell that she was having a motion or
okay. Currently, is she bedridden? Currently, is she bedridden?
Yes, sir. Yes, sir. Yes, sir.
Is she bedridden? Okay. What is the posture of the child now? What is the posture of the child now? Is that important?
Yes,
Use stiffness is there.
Yes, sir. Sir, posture. Sir,
From the
presently
history.
the child is in.
From the history.
Yes, sir.
Whether she was opistotonic, whether she had decerebrate rigidity, decorticated rigidity, you could have asked that.
She was, sir, she was having right hand contracture, and all other three limbs are in involuntary movement.
Okay. Was there a symmetry of involuntary movements in the right and left, or was
Yes,
there any asymmetry?
Yes, they are symmetrical, sir.
Symmetrical. Then go to the next sentence. Speech. What is the speech problem?
Sir, first she had slurring of speech. Then it progressively involved, and then she could not complete the whole sentences. Then it went to word, half sentence and words, and then progressively she presented with monosyllable word only, ma or pa.
What happened to her hearing and vision?
Sir, vision was intact, and hearing was also normal.
Okay. Was there any ataxia?
Sir, the patient could not able to stand by herself. Sir, she was standing by
Power itself
support
is a
mother.
question. Okay.
Yes, sir.
What do you mean by emotionally labile? What happened?
Sir, suddenly, sir, she was happy and smiling, and suddenly she starts crying.
Okay. What happened to the bowel and
Emotionally.
bladder control?
So bowel and bladder control was intact, sir. So she was tell her mother that I was going
Okay.
to
Go to the next
I
slide.
was going to have this. So
Go to the
yes,
next
sir.
slide. Yeah, several you have put negative history. Leave it. Go to the next slide. Go to the next slide. Yeah. Why did you ask history of measles?
Sir, suspecting of SSP, sir, subacute sclerosing
Okay.
panencephalitis.
Okay. What is the latency between measles natural infection and SSP? Short or long? Short or long?
So,
The
sir, long
latent
distance, sir.
period between measles and SSP is short or long?
Sir, long history.
Long. How long? How long? Months, years,
For up to the years,
months or years?
sir, years.
Years. Usually it's around approximately 7 years. 7 years, but it can occur as early as 1 month. You know, measles can cause encephalitis by 2 or 3 methods. One, during the acute phase itself, you can have a acute meningoencephalitis. Second, you can have a para-infectious encephalitis or a demyelinating encephalitis after a few weeks or months. Third is the slow virus disease of SSP. Three things, both or any of the three can occur following measles. Right? Good. Why did you ask about similar episodes in the past? And why did you ask for blood transfusion? Yes? Hello? 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 Why, why did you ask for history of blood transfusion? Why did you ask for history of similar episodes in the past? Hello? Naresh, there's some problem with the connectivity. Naresh.
Yes, sir, I am calling.
Dr. Seema, you can also join the discussion. You can start asking questions. Dr. Seema, please.
Yes, sir, I am there, sir. Yeah.
Yeah, please go ahead. Continue.
I think he has lost. Yeah, he has
60 लाख
joined.
रुपए का ऑर्डर हुआ है.
He has lost the
He's
connection.
back, sir. He's back. Yeah.
Good evening, Dr. Ashok.
काम मशीन भी है.
Atul, voice नहीं आ रहा. You continue. Atul?
Yes.
Yeah.
Yes, sir.
Yeah, hello.
Yes, sir.
Why did you ask for history of blood transfusion? Why did you ask for history of similar episodes?
Sir, in the history of sir similar episode, I am asking for any case of any siblings. Sir, similar episode in the past, sir. If there is similar episode in the past, there may be history of another abnormal body movement or seizures.
Pardon? In which condition you get such recurrent episodes?
Sir, seizures.
Demyelinating disorder. Demyelinating disorder. See, unlike infections which come, hit and go, unlike space occupying lesions which cause progression, unlike neurodegeneration which cause progression, in a demyelinating disease, the child may recover completely or partially, then come back with similar episode, typical demyelinating disorder. That is where you get remissions and exacerbations in neurology. That is one. History of blood transfusion, why did you ask? You have mentioned, you only mentioned Atul. It is relevant. Blood transfusion, because however safe.
Sir, any viral which can cause viral encephalitis?
HIV can still be transmitted by, because nowadays everything is screened, but still there is a slender chance of a transfusion-induced HIV, which can cause, which can behave like a neurodegenerative disease or a demyelinating disorder. Okay.
Yes, sir.
Right. Yes, Dr. Seema, you can continue.
Sir, right now, nothing from my side, sir. We will go to clinical examination.
Let him go to the summary and then we'll discuss the
Yeah.
summary. Go to the summary slide, Atul.
Yes, sir.
You're not able to share the screen or read out the summary.
Yes, sir. Not able to share the screen.
Okay, doesn't matter. You read out the summary.
Yes, sir.
You had written some summary.
Sir, Geeta Yadav, 13-year-old female, was born out of non-consanguineous marriage, developmentally normal, right-handed, presented with involuntary movement of all 4 limbs in 9th month, with decreased school performance, difficulty in walking, dysarthria, behavioral changes, with no significant past and family history. I would like to consider my probable diagnosis of a movement disorder.
Movement disorder is a very vague term. Okay. Now, you always use the term CNS, cause, nature, and site. You always identify the cause of the nervous system lesion with history. Nature also from the history. Only the site from physical examination. Now tell me, is there a neurological problem in this child or is there a multi-system problem in this child?
There is neurological problem also, and psychiatric problem also.
No, is there a neurological problem or a neurological come multi-system problem? It looks like an isolated neurological problem. Of course, what you have put is neurological plus psychiatric. Okay. Now tell me whether this disorder is acute, subacute, chronic. Is this disorder
Chronic, sir.
Chronic. Is this disorder an acute static one or a chronic progressive one or a relapsing one?
Sir, chronic progressive.
Chronic progressive. Now, if it is chronic progressive neurological disorder, which parts of the nervous system are affected from the history? From the history, which parts of the nervous system are involved? Please make it full screen.
Yes, sir.
Which parts of the nervous system are involved?
Sir, cortex is involved, and sir, basal
Why do
ganglia.
you say cortex is involved? Why do you say cortex is involved?
Sir, behavioral changes is also present.
Very good. Behavioral changes. Yes, that is one. Which portions of the cortex are involved if there are behavioral changes?
Sir, the frontal cortex.
Frontal lobes are involved. Okay.
Personality changes,
Right.
changes.
Then what other cortical involvement is there in this side?
Sir, she was also having memory problems.
Memory problem. What is that indicates what?
Yes, sir.
Again, frontal lobe plus multiple areas of bilaterally. That's what happens when memory is lost.
Yes,
Okay,
sir.
right. Then,
And sir, also having extrapyramidal symptoms.
yeah, indicating that it could be basal ganglia
Basal ganglia
involvement.
problems.
Okay. Why does she have difficulty in walking? And you said tone is increased.
Yes, sir.
What
Sir,
does it indicate? What does it indicate? Increased tone, difficulty in walking.
Sir, hypertonia, sir, upper motor neuron lesion.
That indicates subcortical involvement.
Yes, sir.
Isn't it? And decreased school performance again indicates, intelligence problem.
Intellectual. Yes, sir.
Okay, right? So,
Yes, sir.
is it unilateral or bilateral? Symmetrical or
Sir,
asymmetrical?
symmetrical.
Symmetrical, bilateral. Are all the four limbs equally affected or upper limb
Yes,
more
sir. All
affected
the
than
four
lower
limbs are
limb?
equally affected, sir.
Indicating it's a diffuse cortical and subcortical involvement both sides.
Yes, sir.
Now coming to the etiology, what do you think is the etiology?
Sir, causes can be, sir, in the
What are the possibilities? What are the possibilities? How long is this happening now? 9 months.
yes, sir. Sir, it could be
Yeah. What are the
Sydenham's
possibilities?
chorea. It could be, sir, Sydenham's chorea or
No. Before that, I want to ask you:
yes,
is
sir.
this child fitting into criteria of neuroregression? Is this child having neuroregression? Yes, no.
Yes, sir. Yes, sir.
What are the criteria for neuroregression you should apply, and what criteria are there in this child?
Sir, decreasing of school performance and
No.
difficulty.
What do you mean by that? When do you use the term neuroregression? What are the criteria to say? What are the criteria to say any child has got neuroregression? That's my question for you. When do you use the term neuroregression? And does this child qualify herself to be having neuroregression?
Yes, sir. She qualifies to be neuroregression.
What are they qualify? That's what I'm asking you.
Sir, what she has previously learned, she she
You
lost
must
that.
remember there are 3 criteria to say any child has neuroregression. 3 criteria. The criteria are: 1, arrest of development and loss of previously acquired milestones. 2, documented history of normal development prior to the onset of illness. 3, all this should be there for at least 3 months. Does this child have neuroregression or not?
Yes, sir. This child was having
Absolutely,
neuroregression.
yes, absolutely. If it is neuroregression, what do you think is the cause for the neuroregression? Etiology from the history. Is it infection, inflammation, autoimmune disease, malignancy, space occupying lesion?
Sir, it can be infections, metabolic disorder.
Which metabolic disorder can present like this?
Sir, Wilson's.
Which metabolic disorder can present
Sir,
exactly
Wilson
like
disease.
Wilson's? Is this Wilson's disease?
Yes, sir.
Very much possible. Very much possible. Okay.
Yes, sir.
Gradual progression, neuropsychiatric manifestation, choreoathetosis, spasticity. This can well be Wilson's disease. That is number 1. Number 2.
Sir, seeing the coriform movement, it can be Sydenham's chorea.
Rheumatic chorea.
Rheumatic chorea.
Rheumatic chorea does not progress like this, be resulting in child becoming completely inactive and not ambulant, and so much of regression. You said so much behavior changes, mild emotional ability will occur, but not this sort of great speech disturbance. That is very much against rheumatic chorea. Usually in 3 to 6 months, rheumatic chorea will spontaneously recover. It doesn't lead to sequelae. Okay. 2,
Yes, sir.
3. What else? Tell me which neurological disorder can affect the brain, all parts of the nervous system, central nervous system, like this, multiple areas, and progress without fever. Excellent. Somebody has put it in a chat box. Encapsulo, they have put it here. She has put it as ADEM. Yeah, yeah, any demyelinating disorder, multiple sclerosis, ADEM. Okay, nowadays, two other diseases other than multiple sclerosis and ADEM we consider. What are those two diseases? New entries. Anybody can put in the chat box, PGs. Two new entrants to the list of demyelinating disorders, particularly when there is fever. One is autoimmune encephalitis, the other is MOGAD, MOG antibody disease. These two conditions you have to consider, other than multiple sclerosis, MOGAD antibody disease and your autoimmune encephalitis. Particularly in an adolescent girl, you have to consider autoimmune encephalitis, but that is usually acute, not this sort of slow progression, but it cannot be ruled out simply with this history. And many an adolescent girl with autoimmune encephalitis may have ovarian teratoma, resulting in autoimmune encephalitis. Right? Other than this, you have to consider rare disorders like, toxins, lead poisoning, heavy metal poisoning, drugs, okay, and even nutritional causes like, thiamine deficiency, B12 deficiency can cause psychosis with this sort of disturbance, but not choreacidosis. And more importantly, CNS vasculitis. Hello? Hello, can you mute, please? Can you mute, please? Other than this, CNS vasculitis due to lupus erythematosus or CNS, vasculitis per se, CNS angiitis can cause presentation like this. Okay.
Yes.
These are the thoughts which come to my mind. In all probability, without fever, this sort of neuroregression involving multiple areas of the nervous system, the possibilities are either it's a neurometabolic disorder or a slow virus infection like SSPE or an autoimmune encephalitis or a demyelinating disorder. Okay. The last consideration should be on a space occupying lesion, but it's very, very unlikely. Unlike, suppose, for example, a child has got multiple granulomas,
Yes.
tuberculomas, multiple cysticercus nodules in the brain. They can present like this with multifaceted CNS manifestation. Okay. Of course, if there is no spasticity, CNS childhood psychosis also has to be considered in the differential diagnosis. Late onset neurodegenerative diseases, particularly those involving the gray matter, because there is so much of disturbance of the behavior, dysarthria, etc., has to be considered. Okay, right. Dr. Seema, you have any more questions? Otherwise, we can ask Dr. Atul to go for presentation.
Sir, no more from my side.
Do you have any questions?
No, sir, right now, no more
Okay.
questions.
Dr. Atul, you can discuss the physical findings with Dr. Seema. Yeah, please go ahead.
On a general examination, patient was lying on bed, awake, conscious, irritable with involuntary movement of all four limbs, and right upper limb was in shoulder in adduction, elbow in full flexion, wrist in flexion. Patient is thin build, no pallar, icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy seen. Vitals were normal. Patient was vitally stable. Anthropometry, patient is moderately underweight and stunted, and as per BMI, she is undernourished. Head-to-toe examination.
Yeah, one minute. Show me the anthropometry. See, BMI 16.5 is normal, yeah. You don't call it as undernutrition. In fact, if you go to Nelson and see, Nelson says BMI less than 15 is to be labeled as underweight. So 16.5 is not undernutrition. It's not correct.
Yes, sir.
30 kgs is, if it is BMI is so 16.5, it is only is normal. Less than 15 is underweight.
Yes.
Okay. And even length 152 centimeter. You have to have taken the length of the parents before you talk. You mentioned that she is stunted.
No, sir.
Right?
Yes, sir.
Okay. Right. She has attained menarche, isn't it?
Yes, sir.
Okay. Of course, if you are a female student, definitely you are expected to give the SMR at this time. Okay. Right. Go ahead.
Head normal in shape and size. On examination of eyes, there is a circumferential grayish brown ring encircling iris, which was visibly in both the eyes. No cataract, ptosis, nystagmus or squint seen, and facial grimace present. No facial dysmorphism or asymmetry noted, and no oral ulcers, no caries present. And on ear, nose, and throat examination appears to be normal. No neurocutaneous markers present. On CNS examination, higher mental functions, the patient is conscious, orientation cannot be commented, and on appearance and behavior, patient was awake, smiling, and obeys simple command. Speech and language were disarticulate.
Why you are saying 1 minute? No, Atul, why you are saying orientation cannot be commented?
So she was not able to speak properly. She,
No. You have said that orientation cannot be commented. What do you mean by that? Why?
orientation to time, place, and person. Yes,
Yeah,
sir.
she recognized you as a doctor.
Sir,
Did you say hello to her? Did she respond? Was there any eye-to-eye contact?
Yes, sir. Eye-to-eye contact was present.
Then how can you say orientation cannot be commented? You could have asked her a few questions.
And she was conscious also.
Yes, sir. Yes, ma'am. She was conscious.
Dr. Seema, you want to ask something?
Sir, he mentioned the patient was, he has mentioned the patient is conscious. So at least was the patient expressing herself? Did you ask questions like, where are you? So are you, where are you? So the voice was not clear, as you said, it was, there was speech.
I have asked.
But was she able to, like, he's your father, who is he? So leading questions might come, but was there any expressions also?
Sir, ma'am, she was recognizing her parents, and if asked to eat food, and she used to nod.
No, Dr. Atul, the point that Madam and me are trying to tell you is, she is awake.
Yes, sir.
You have put a term called smiling faces, and you have said that she is obeying command. Could I ask her a few questions? Hello, where are you? Where are you from? Without saying.
Sir, she was not responding to any command.
You mentioned that. You should have mentioned that. That means she is not oriented. So you cannot say cannot be commented. That's what we are trying to tell you.
Yes, sir.
It can be commented. You could have assessed the orientation by asking her, where are you? Where have you come from? Did you have your breakfast? How are you? Like that. You are saying she was obeying simple command.
Yes, sir.
Okay, go ahead. Okay. Dr. Seema, you can ask him.
Yes, so you move ahead with speech, then memory. Sleep pattern, how did you know that was altered?
Ma'am, sleep pattern, ma'am. Normally, ma'am, she used to sleep earlier 8 to 10 hours a day, and ma'am, on admission and on past few months, the sleep hours was reduced, ma'am, 4 to 5 hours or.
Okay, move ahead.
Cranial nerve examination.
By sleep pattern altered. What is the alteration?
Sir, speech pattern, sleep pattern altered.
So
Sir,
what do you mean by sleep pattern altered?
Sir,
Is she
normally,
sleeping more? Is she sleeping less?
sir, she was sleeping less than.
You
than
mentioned that instead of, yeah, you mentioned that instead of saying blindly sleep pattern altered. Okay, right, go ahead.
Cranial nerve examination. First cranial nerve could not be assessed, and on second cranial nerve examination, visual acuity, color vision, field of vision could not be assessed, but both direct and indirect light reflex were present.
Anything abnormal in the cranial nerves? Anything abnormal in the cranial nerves?
No, sir.
Go ahead, skip it.
Yes, sir.
Yeah.
The motor system examination, bulk of the muscles normal in all four limbs.
Do you have pictures of the child?
Yes, sir. Yes, sir.
Go ahead.
Sir, tone, sir, both, sir, all the four limbs tone were hypertonia, and power in all joints.
One minute, don't, 1 minute, 1 minute only. Is there spasticity or rigidity?
Sir, rigidity.
Yeah, you should make it because it tells you that the problem is extra pyramidal rather than pyramidal alone.
Yes, sir.
Go ahead.
The power was equal in all joints, 4/5, and deep tendon reflexes, knee jerk and ankle jerk was brisk in bilateral limbs. Superficial reflexes, all superficial reflexes are diminished, but plantar extensor in bilateral limbs. Sensory system examination, superficial sensation was intact, tactile touch, pen temperature was intact, but cortical sensation could not be tested. Cerebellar signs could not be tested, gait could not be tested, autonomic nervous system was normal, and no signs of meningeal irritation.
What do you mean by the statement autonomic nervous system normal? What did you test?
Sir, heart rate, respiratory rate,
Blood pressure, bowel and bladder also, isn't it?
Yes, sir.
Spitting, bowel and bladder. Okay, right, go ahead.
Sir, other system examinations were also normal, cardiovascular, respiratory, and
No, 1 minute. Atul, you said that there is some asymmetry. But in the tone, reflexes, power and all, everything is symmetrical.
Sir, there is symmetrical involvement of all four limbs.
Okay, okay. But what the mother told you was asymmetrical, but what you found was symmetrical. Am I right?
Sir,
Okay.
sir, teacher first noticed movement started from right hand and then
Okay, okay. Did she have any involuntary movements while you were examining?
Yes, sir. She was having involuntary movement.
You have the video or the pictures?
Yes, sir. Yes, sir. I have video.
Yeah, you go ahead. Go ahead. Go ahead.
And sir, cardiovascular system, respiratory system.
Systems, everything is normal or abnormal? Anything abnormal or normal?
Sir, normal.
Okay, then you show us the pictures in the video.
Sir, this is the video.
He has good eye contact with you. He's
Yes,
even
sir.
smiling at you.
Yes,
Yeah.
sir.
He tends to keep both the upper and lower limbs flexed,
Yes, sir.
internally rotated. Right?
Sir, externally rotated hip.
Okay. 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 Yeah.
Both lower limbs appear wasted, no?
Yes, ma'am. Pardon, ma'am.
Does the limbs appear wasted?
Yeah. What Dr. Seema is saying is correct. The lower limbs, definitely there is wasting. Even in the upper limb, the muscles are wasted. That may be because of chronic
Yeah, chronic
inanition.
malnutrition and disuse atrophy.
Yes, ma'am. This is a trophy.
Okay, you have the eye picture of the KF ring. Yeah.
Yes, sir.
Can you? Okay, looks like a KF ring. Of course, very difficult without a slit lamp.
Yes.
Okay. Does he have any involuntary movement involving the eyes?
No, sir.
No.
Sir, there is no movement in the eyes, like
Any
nystagmus or-
tremor? Any tremor?
No, sir.
Any
No, sir.
ataxia while sitting? Like he was tending to fall, like we could not see in the video that he was falling.
Ma'am, she was not able to sit with.
Acha, she was sitting with support just.
Yes, ma'am. She was sitting with support.
Yeah. Okay.
Go ahead, Dr. Seema. You can continue.
Yeah, can you tell me why normally they say ki the ring is greenish or bluish as grayish as you mentioned. Why particularly this color has been mentioned? For Wilson's, like the ring, KF ring is present in Wilson's mostly. So why is it so?
Ma'am, on naked eye, it appeared grayish brownish type, but on slit lamp examination, it appeared to be KF ring on optical examination. The brown.
So why is it green or blue? They say it is just because of the copper deposition that give it a this color.
Yes, yes, ma'am.
Yeah, blue, green, or what you are seeing with the naked eyes is grayish. Okay, you move ahead, then we will put questions for you.
On blood investigations,
No. Don't talk about blood investigation. Tell me your summary of the history and physical findings in one sentence and give a probable diagnosis. Forget the investigation. Investigation we'll discuss later. This is clinical benefit.
Geeta Yadav, 13 years old female, was born out of a non-consanguineous marriage, developmentally normal, right-handed, presented with involuntary movement of all four limbs since 9 months, with decreased school performance and difficulty in walking. Dysarthria and behavioral changes are present with no history of drug intake and no significant past and family history. On general examination, child has a facial grimace, undernourished, widely stable, KF ring present in both eyes with rigidity and coriform movements in all four limbs, with DTR brisk and plantar extension, with no cranial nerve involvement and no sensory deficit, no bladder bowel dysfunction, with liver function normal, and with serum ceruloplasmin 8.6, with low serum ceruloplasmin, and with high 24-hour urinary copper, and MRI findings suggestive of metabolic disorder.
Okay, forget MRI, liver function test and all that. Suppose you are the physician in charge of this patient. You have taken the history, you have done a physical examination, and you have made out a KF ring, and you have made out a diagnosis of Wilson's disease. What other differential diagnosis at this point of time you would have considered other than Wilson's disease? Already in the history, I gave you a clue that this fits into neuroregression.
Yes, sir.
If it is
Uh,
neuroregression, what are the conditions you will think of in a 13-year-old girl who regressed? If it is neuroregression, are you thinking of a neurodegenerative disease? Hello. See, fundamentally, as a pediatrician,
yes, sir.
the moment you have a diagnosis of neuroregression,
The primary biliary cirrhosis.
your primary aim and responsibility are to find out, is this truly neuroregression? And if
Yes,
it
sir.
is neuroregression, what is the cause? If it is neuroregression or neurodegenerative disease, is it white matter or gray matter? Is it congenital
No,
and
sir.
inherited? And do you have any
Inherited
clues
disorder.
to diagnosis? That these are the questions should come to you. Now, my first question is, if this is neuroregression, you are considering a diagnosis of a neurodegenerative disease. Is this gray matter disease or white matter disease?
Sir, this is a gray matter involvement.
Why? What are the differences between gray matter disease and white matter disease clinically? Clinically, how do you differentiate? Can anybody put in the chat box? How do you differentiate a gray matter degenerative disease from a white matter degenerative disease? Very simple. A gray matter degenerative disease produces more often dementia, whereas a white matter degenerative disease produces more often spasticity. Okay.
Yes, sir.
Gray matter degenerative disease, because of cortical involvement, may present with behavior disturbance and seizures more often than white matter degenerative disease. Peripheral neuropathy is a feature of white matter degenerative disease. Optic atrophy is a feature of white matter degenerative disease, whereas retinitis pigmentosa, pigmentary atrophy is a feature of gray matter degenerative disease. Hearing deficit is more a feature of gray matter degenerative disease. Right? Cherry red spot. Is it white matter or gray matter? Usually. Cherry red spot. Is it a feature of gray matter degenerative disease or white matter degenerative disease? Cherry red spot. What is the prototype disease which causes cherry red spot? Tay-Sachs. Tay-Sachs is a gray matter degenerative disease, right? Okay, right. On a similar note, a gray matter degenerative disease is more likely to have microcephaly than a white matter degenerative disease. Cerebellar signs present are gray matter or white matter? Okay.
Gray matter.
Right? These are all some of the points. And in this child, cognitive impairment is so much, behavior impairment is so much, right? So much of dementia has occurred. This fits into more of a gray matter degenerative disease. Okay, gray. And once you have extrapyramidal involvement, the prototype disease which you have to rule out is Wilson's disease. And you rightly look for a KF ring. And this is probably neuro-Wilson's. Probably neuro-Wilson's. The closest differential diagnosis in this child would be subacute sclerosing panencephalitis.
Yes, sir.
Okay. How does it manifest? What are the manifestations? When do you start suspecting SSP in a child? Characteristically, SSP causes progressive dementia in a previously normal child, and it causes characteristically myoclonic seizures. Myoclonic seizures. The myoclonic seizures are called timed myoclonic seizures. Every 5 to 10 seconds, in fact, my professor of neurology used to say, you can take an EEG and take a walk on the EEG. Every 5 to 6 seconds, there is a myoclonic seizures. Okay. a very, very characteristic. Dementia occurs, spasticity occurs, and the child becomes bedridden in a few months to a year. Myoclonic seizures are characteristic. Prognosis is extremely bad. That is SSPE. The third condition which one has to consider in this child is basal ganglia degenerative diseases, disorders. There are many. I'm not very familiar with those pelizaceous nerve tracker disease, which occurs in very early age. Okay, some degenerative disease of basal ganglia occurring at older age group, including rarely Huntington's chorea, which can have onset in adolescence, usually in the second decade. Right?
Yes.
Heavy metal poisoning can behave like this. Right? Moya disease, vascular occlusion bilateral can present like this. Autoimmune encephalitis can present like this. MOGAD antibody disease can present like this. But the absence of fever, such a long drawn story, makes the diagnosis unlikely. Rarely, multiple granulomas in the brain, tuberculoma or cysticercosis, can always present like this with progressive spasticity and your extrapyramidal. CNS vasculitis is another consideration. These are all the possibilities one has to consider. Okay?
Yes.
Dr. Seema, please take over. I'll come in later. Yes, Dr. Seema. Hello?
Yes, sir. I'm there, sir.
Yeah. You continue.
So should we move ahead, sir, after the summary?
Yeah. Go ahead.
Investigations and management part.
Go ahead.
Blood
Please
investigation.
Make it full screen.
On blood investigation, complete blood count was normal, and liver function test was also normal. Renal
Does that
function
rule out Wilson's disease?
Yes, sir.
Does that rule out Wilson's disease? Absence of abnormalities in liver function test.
No, sir. It does not rule out.
Absolutely no. Your answer should be liver function test can be absolutely normal in neuro Wilson's.
Yes.
Right?
Yes, sir.
Normal liver function disease does not rule out Wilson's disease.
Wilson disease.
Go ahead.
And thyroid function test was also normal. And
why did you do the thyroid function test?
Sir, in case of hyperthyroidism or thyrotoxicosis, they are also movement disorder.
Okay. More importantly, hypothyroidism can occur in autoimmune encephalitis. You know, one of the antibodies present in autoimmune encephalitis is antithyroid antibodies. Okay, right. Which can cause hypothyroidism.
Yes.
C-reactive protein and was negative, ASO titer negative, and direct cum test was also negative. Throat swab test, no growth, and ECG
Why was
normal.
throat swab culture done? Why was throat swab culture done?
Sir, for rheumatic fever, acute rheumatic fever.
What? Child doesn't have fever, doesn't have sore throat. Even if you grow group A beta hemolytic streptococcus, it only indicates it's a carrier. Doesn't mean anything. It's a waste of money. In fact, one of the points you must remember, rheumatic chorea is a disease which is often an isolated manifestation of rheumatic fever. Majority of children who have rheumatic fever do not have rheumatic arthritis, rheumatic carditis. In fact, Nadas used to mention, pediatric cardiology book, rheumatic chorea can come before or along with or after carditis, anything, any combination. In fact, every child who has rheumatic chorea should be given rheumatic fever prophylaxis because next attack of streptococcal infection can lead to carditis.
Yes, sir.
Okay, and often rheumatic chorea is an isolated manifestation. And it doesn't cause any elevation of ASO, it doesn't cause any elevation of ESR. Throat swab culture is not at all required. Right?
Yes.
In fact, today there is another disease which closely resembles rheumatic chorea, new terminology has come. What is the disease? Anybody can put in the chat box, PGs. Differential diagnosis of rheumatic chorea. Pandas. Have you heard of pandas? What is pandas? Post-streptococcal autoimmune neuropsychiatric manifestation. Okay. That is following streptococcal infection. You can have tics, behavior abnormality, minor coriform movements without rheumatic chorea. That's called pandas. Okay.
Yes, sir.
This is one of the complications of streptococcal infection. Right? And a differential diagnosis for anybody who tics and behavior problems. Right? Go ahead.
ECG was normal, urine routine normal, serum ceruloplasmin was low, and 24 hours.
Plasma is normal or low?
Sir, serum ceruloplasmin is low, 8.7. Sir, normal it should be 20 to 40 mg per deciliter.
Okay. In which other neurometabolic disorder, serum copper and ceruloplasmin will be low?
Sir, acelloplasminemia and autoimmune hepatitis. And
No. I am asking which other neurometabolic disorder you can have low serum copper and ceruloplasmin, in which copper is used as a therapeutic agent. Binky's kinky hair disease.
Yeah.
Binky's kinky hair disease, the serum copper and ceruloplasmin are low. You give copper histidine injections subcutaneously as treatment for improvement. Okay, go ahead.
sir, 24 hours urinary copper was high, that is 166 microgram per deciliter.
Serum copper?
Sir, serum copper was not the
You expect it to be high.
diagnostic. Yes, sir.
Okay. Go ahead.
Yes, sir. Sir, on MRI brain, symmetrical T2 hyperintense intensity noted in bilateral
You have the picture? You have the picture?
of MRI.
Yeah.
Sir, I'm not having a picture of sir.
Okay, please read out.
Yes, sir. Sir, symmetrical T2 hyperintensity noted in bilateral lentiform nucleus and bilateral thalamus.
I have a question to you. Yeah.
Yes, sir.
Yeah. I have a question to you.
Yes, sir.
Which acute neuroinfection resembles Wilson's disease? Similar findings.
G.
Anybody can put in the chat box. Which acute neuroinfection? Excellent. Somebody has put Japanese encephalitis. It closely resembles Wilson's disease. Very similar finding. Okay. Right. Go ahead.
Yes, sir. Symmetrical T2 hyperintensity noted in bilateral lentiform nucleus and bilateral thalamus with the periaqueductal white matter in posterior half of pons and in splenium of corpus callosum with mild diffuse atrophy of bilateral cerebral hemisphere.
Go ahead.
Non-differential, it could be Wilson, Sydenham's chorea, or Huntington's chorea.
See, the rheumatic chorea is absolutely out in the diagnosis because there is so much of dementia which doesn't occur in rheumatic chorea. Right? It doesn't cause so much worsening. And I have not seen a rheumatic chorea child being incapacitated like this at all. Huntington's chorea, yes, early onset is a possibility. Okay. Other than that, an adolescent girl, you should always consider lupus erythematosus, CNS lupus, as one of the differential diagnoses. You should do ESR and you should consider doing ANA. Of course, ophthalmologists must be asked to look for any uveitis in addition to KF3. Okay, go ahead.
Yes.
Did you get an ophthalmologist opinion?
Yes, sir.
What is the opinion?
Sir, ophthalmological examination, they commented only cave ring in the fundus was normal.
Cave ring is present or not?
Yes, sir, cave ring was present.
Okay, fundus was normal. That's good enough, right? How do you manage this child? How do you confirm the diagnosis? You have confirmed the diagnosis now, or
Yes, sir.
how will you confirm the diagnosis? Today in
Uh,
2023, how will you confirm the diagnosis?
Sir, sir, by Leipzig scoring system.
You should do a clinical exome sequencing
Yes, sir.
and pick up the genetic mutation. In addition, you should also confirm it in the parent because it is an autosomal recessive disorder,
Yes, sir.
and it is prudent for you to advise the parents to screen all the siblings. That is very important as part of your counseling. You should ask them to investigate. You should get them all screened for KFing,
Yes,
and you should ideally do mutation screening for all siblings.
yes, sir.
Okay, having
Yeah.
confirmed Wilson's disease, so that the same thing doesn't happen to the siblings.
Siblings.
Okay. What did you do for this child in terms of treatment? Did you do renal function test for this child?
Yes, sir. Renal function test was
Why
normal.
should you do renal function test for somebody with a diagnosis of Wilson's disease?
Sir, the copper deposition mainly occurs in liver, kidneys, and
Why should
brain.
you do renal function test? What do you look for?
Sir, renal tubular acidosis.
Yeah, renal tubular acidosis. They can present with rickets. They can present with renal tubular
Stones.
acidosis. They can present with diabetes mellitus, right? Renal glycosuria can occur, right?
Yes, sir.
Right. Fanconi syndrome, quite right. Correct. Renal tubular acidosis, right. What did you do?
Sir, restriction of copper-rich foods like nuts, chocolates, liver, and
Very
shellfish.
correctly, you have put nuts, chocolate, shellfish, and liver should be avoided. Okay, good. Then
And sir, copper chelators like D-penicillamine, trientine.
you have to be careful in introducing penicillamine and zinc together because it can worsen the neurological symptoms. Initially, you have to be careful, right?
Hypersensitivity reaction of penicillamine.
Okay. Okay. Right. That is regarding this. What other advice will you give to the parents?
Sir,
You should tell them treatment is lifelong.
yes, sir. Lifelong treatment.
Treatment is
Lifelong.
lifelong. Child has to be on copper chelation therapy.
Yes, sir.
And if unfortunately the child develops end-stage liver disease, may end up requiring liver transplant also.
Yes.
Right? Yes, Dr. Seema, you can add.
Yes. So how will you assess the side effects of the drugs? Like usually what I have read, penicillamine should not be given in cases of neurological involvement or in Wilson's, because they say that further deteriorates the neurological condition. They say usually we should give zinc, we should give trientine as the first line, and a newer drug, this tetrathiomolybdate should be used. So can you tell me if we are using penicillamine, what precautions you should take, and like suppose it, so what all things you should look for before administering penicillamine, and what are the common side effects of penicillamine?
You
have to monitor drugs.
Hypersensitivity.
Yeah.
It can cause hypersensitivity reaction, like Goods-Pasteur syndrome.
Nephrotic syndrome. Penicillamine.
syndrome.
Yeah.
Nephrotic syndrome.
Proteinuria is very commonly seen, proteinuria, and you have various rashes skin rashes you have, pemphigus-like presentation. Apart from that, these patients have GI symptoms in the form of dysgeusia, loss of taste, and diarrhea also in some cases.
You are very right, madam. You mentioned correctly. If we give penicillamine, this child will deteriorate. It's better to start with zinc, that too very carefully, slowly increase the dose, and then watch for deterioration. Okay.
Yeah, we have to give pyridoxine also is mentioned
Yes.
with penicillamine whenever you are giving.
Yes.
And you have to monitor for CBC. That is very important. You have to see for platelets because
Okay.
these patients have low platelets and leukopenia also.
Yes, madam. Your voice is breaking.
Sir, I was
Hello?
mentioning, hello, am I audible right now, sir? Hello?
Hello. Yes, ma'am.
Your voice is breaking, madam.
I think, sir, probably some network issue. I'm going to close my.
There is some connectivity.
Yeah, some connectivity probably, sir. I was mentioning, sir, that penicillamine, while being administered, a complete blood count should be done because these patients often land up with thrombocytopenia and leukopenia.
Correct.
Yeah.
Okay. Okay. Anything else from Dr. Seema? Hello?
Yes, sir.
Please go ahead. Continue.
Seema madam, you are there?
Yes, yes. So basically in Wilson's, where does the defect lie? What I read is it's a basically a single gene is it's a monogenic disorder with varying variation in alleles that is there.
Yes, ma'am.
And where is the basic defect in the system?
Defect is at the chromosomal level, ma'am, chromosome 13 to
So
14.
what does it cause?
At the 80, mutation in ATP7B gene, which causes a defective protein of P-type ATPase, which helps in copper binding to ceruloplasmin and excretion. That is defected. So there will be copper accumulation, and
basically there is a defect in ceruloplasmin itself.
yes,
They
ma'am.
say the ceruloplasmin is formed by 6 copper molecules, 6 copper atoms in it.
Yes,
so this there is lack of copper in the ceruloplasmin. So the ceruloplasmin itself is defective and it gets degraded very easily. Therefore, the copper is not bound. It doesn't get bounded to ceruloplasmin. So the copper accumulates and this leads to, it is not secreted in bile.
Yes,
So
ma'am.
this leads to urinary losses of copper.
Urinary loss of copper.
So therefore, should we do serum copper levels? Is it important in the diagnosis of Wilson's disease?
We can do, but
yeah, what I read, serum copper won't be helpful. It might be high or it might be low. So usually they say it may be low, but high it usually occurs when there is a sudden involvement of liver and acute damage of liver occurs that leads to release of copper in the circulation. So then you get high serum copper. Otherwise, you may have normal or low serum copper also. So serum copper is not the diagnostic test. So urinary copper is very important. And as you said, serum ceruloplasmin level. And at the most, then you can go with liver biopsy for estimating the copper content in the liver.
Yeah, 2 or 3 things. One, Wilson's disease commonly manifests as chronic hepatitis. Rarely can present as acute fulminant hepatitis. 2, The older the age, the more are the chances of Wilson's presenting with neurological manifestations. 3. The peculiarity of hepatitis in Wilson's disease is that the SGOT goes up more than the SGPT in Wilson's. Just like drug-induced hepatitis, in Wilson, the SGOT will be in 500. The SGPT may not go up beyond 100, 150. Rarely, Wilson's can present as an acute hemolytic anemia, severe anemia, or may present with Fanconi syndrome or renal tubular acidosis. The earliest manifestation of Wilson's are very similar to rheumatic chorea or SSPE with dementia, handwriting difficulty, dystonia, dysarthria, and then choreoacidosis. Sometimes both hepatic and neurological manifestations can be combined in the same patient. Younger the patient, more are the chances of hepatic manifestation. The older the child, more are the chances of neurological manifestation. Right? It is an eminently preventable disease, treatable disease, and nowadays, liver biopsy in Wilson's is very rarely done because we have got facilities for genetic diagnosis of the disorder. As Madam rightly put, you don't go by serum copper. At the most, you do a urinary copper. Even that, if it is not high, it doesn't rule out Wilson's. You have to give penicillin challenge and then measure increase in serum copper. Right? KF ring, if present, indicate that there is neurological involvement in a given child. And KF ring may not be there in all forms of Wilson's disease with hepatitis. It may take a longer time for KF ring to form. The mode of inheritance is autosomal recessive. Right?
Yes.
Yes. Okay. If Dr. Seema, you want to add something? We can close the session.
Yeah, sir, regarding hemolytic anemia, this is a non-immune hemolytic anemia.
Absolutely right. Coombs negative.
Coombs negative. That's all, sir.
Okay.
Sir.
Very well done, Atul. You presented very nicely. We wish you all the best. Over to Dr. Naresh. You can stop
Sir,
sharing.
Bala sir, just one point I wanted to ask, sir.
Ask Atul to stop sharing the screen.
Yeah, probably this child had subtle manifestations before the clinical manifestations, though the history is 9 months.
Atul, you stop sharing the screen. Atul? Yeah, go ahead. Go ahead.
Probably this child had manifestations much earlier than 9 months. History is of 9 months, but maybe subtle manifestations were occurring much before that. Probably that was the thing, sir.
If you go deep into the history, you might find that the onset had been earlier than 9 months. I agree with you.
I just wanted to ask, sir, why some children they presented neurological manifestation without hepatic manifestations? This child is 13 years only, but no hepatic manifestations, no jaundice anytime, and suddenly presented neurological. Like, what was any characteristics which differentiate? Like, what is the reason? Just
sorry, Naresh, I don't know that much. Maybe Seema, you might be able to answer the answer.
Yeah, because certain food products are rich in copper, sir, and then the copper deposition start. Maybe he might not have been consuming that rich in copper.
now, what my question is, why this child is not having hepatic manifestations straight away? This child has neurological manifestation. Why some children present only with hepatic? Like, that's what I was asking. Okay.
I don't know. I don't.
Yeah, fine. So this was a really very nice case presentation by Dr. Atul, and he was very confident and he answered almost all the questions. I was really impressed the way he presented. Initially he said, sir, maybe I cannot present, I want to postpone like this, but he was very cool. And thank you for bringing us this wonderful case here, Dr. Atul. And I thank our experts, Dr. S. Balasubramanian, sir, and Dr. Seema Jain, for a wonderful discussion on this case.
Dr. Seema had given very good, very valid points. Dr. Seema has brought out very nice points.
Sir, I have learned a lot from you in this session, sir. Actually, every session I learn from you only. I just know a small bit. That is what I discussed, sir. That's it. Thank you
Thank
so
you, sir.
much, sir, that we are proud to have you here in this.
Okay.
It was really
Okay.
nice case, and I thank all the participants. Our EBM member from Chhattisgarh, Dr. Ashwin Agarwal sir, was also here, and all the senior pediatricians, all my colleagues, all the postgraduates. Thank you very much for being here in good numbers. That motivates us to do more and more for DBAP. And I thank our Zuventus team, Mr. Vijay, and his team for all the assistance and providing us this platform. Thank you again, each and everyone, for making this webinar successful. Thank you, sir. Thank you, Seema madam. Thank you.
Thank you.
Good night,
Thank you so much, Dr. Naresh Mutwani. Good night.